Catherine Gergen
Yep.
Barnett, kick us off.
Terrific. Thank you. And so happy to welcome everybody. My name is Catherine Gergen Barnett, and I am a very proud family medicine physician. I'm also the Vice Chair of Primary Care Innovation and Transformation at Boston Medical Center and Associate Professor at the BU School of Medicine. And most importantly, I'm a very proud member of the Steering Committee of Primary Care for All Americans. So, on behalf of Primary Care for All Americans, I'm pleased to welcome you to tonight's Teach In and Learn in Zoom session. Thank you for joining us this evening. With over 1,600 people from 40 states, District of Columbia, and 350 zip codes, we are reminded of the incredible momentum we are building together to provide primary care to every American neighborhood and community. Thank you for your dedication and commitment to expanding access to primary care across the country. Now, it's my great pleasure to introduce our moderator for this evening, Sophie Ubaha, and to extend my sincere thanks to all of the presenters for tonight's event. I would also like to thank the Primary Care for All Americans Zoom committee, as well as John Wright, Patty Armstrong, and Liv Verratti for organizing this event. Take it away, Sophie.
Hi, everyone. My name is Sophie Ubaha, and I'm a third year medical student at UCSF. I want to start by thanking you all for being here tonight. By joining us, you're helping us build a movement, one that focuses on providing healthcare to people in every neighborhood and community. Primary care for all Americans. We'd love for you to add your name and location to the chat. As a quick reminder, we don't use professional titles here. This space is about working together and valuing the ideas and commitments that will drive this movement forwards. Now, it's my great pleasure to introduce our keynote speaker and my mentor, Kevin Grumbach. Kevin is a professor of family and community medicine at the University of California, San Francisco, where he served as chair of the Department of Family and Community Medicine from 2003 to 2022. He is also a founding director of the UCSF Center for Excellence in Primary Care and leads the Community Engagement Program for UCSF Clinical and Translational Science Institute. Dr. Grumbach's research on the primary care workforce, health equity, and innovations in primary care has significantly influenced health policy and practice. He is co-author with Tom Bodenheimer of the widely used textbook, Understanding Health Policy, A Clinical Approach, of which I'm thankful to have been gifted a copy and is now in its ninth edition, as well as improving primary care strategies and tools for a better practice. As a member of the National Academy of Medicine, Dr. Grumbach has advised congressional committees and federal agencies on primary care and health reform, and he continues to serve on national and California state health policy bodies. He also cares for patients at the family medicine practices at San Francisco General Hospital. Take it away, Kevin.
Thanks, Sophie. That's great. Putting in a plug for the book, that was over and above. Thank you. Thanks for the really sweet introduction. And it's such a pleasure to be introduced by you. Sophie's a wonderful medical student that I've worked closely with over the last couple of years. And it's just that's what gives us hope, right? As we're seasoned physicians for the next generation of wonderful people who will be caring for patients in our communities. Uh, uh, it's a real pleasure to be with you all this evening. Thanks very much to all the team at Primary Care for All Americans for inviting me to share some thoughts tonight. I can see from kind of watching people log on. I mean, there's so many people who are leaders and colleagues and friends in primary care. So I think I feel in good company. So what I want to do is share a bold proposal with you to really sort of go big in what we need to do to really get primary care revitalized in this country. So, I'm an academic at heart, so let me share some slides. So bear with me as I get my slides set up here. All right. So what I'm going to be proposing to you is what we're going to call the Common Fund for the Common Good. The common good, I think, is a familiar term now to most of you from the National Academy's report from a few years ago that really said, there's such evidence on the essential aspect of primary care is the foundation for an effective, equitable, affordable healthcare system, that we should really think of it as a common good. So what I'm going to be going over today is, well, for a common good, we then need a common fund, essentially a unified way of financing it that creates a universal program for primary care services in the United States. So you know how important primary care is. You know how under duress it is, how imperiled it is, the challenges for the workforce, for our people in our communities to find a primary care doctor, to get access to care. So when I think, though, of what's at the root of the problem, it really comes down to this, money. So we spend pennies on the dollar in the United States on healthcare. For every dollar we spend on healthcare services in the United States, we only spend not even quite 5 cents on primary care services, which is just not enough. So we actually did a public opinion poll that one of Sophie's peers in the primary care health policy scholars program at UCSF was the lead author on this report. So we just asked people to say, you know, how important do you think primary care is? Oh, overwhelmingly important. It addresses most of our most of my healthcare needs. And then we said, well, you know, how much out of every dollar being spent in the United States do you think is spent on primary care? And the average person in that poll thought it was 50 cents on the dollars, not 5 cents on the dollar. So I think the public also understands how important primary care is, and they have no clue how little of their premium and tax dollars is actually going to primary care. So if this to me is the fundamental problem, I mean, like many of you, I've been working my whole career on how do we strengthen primary care? How do we revitalize it? How do we transform it? And I have so now just come to the conclusion we just can't make headway unless we have more resources supporting primary care to hire more people, both clinicians, team members, pharmacists, nurses, community outreach workers. We just need a much more robust team to meet the needs of our community. So what's the solution? The solution is, policymakers got to show us the money. We need to invest more in primary care. And as a recent National Academy of Medicine report that committee I serve on, essentially put it simply, we need to pay more and pay differently for primary care. So what I want to talk with you about then is how we do this. The real exciting action across the country in increasing investment in primary care is happening much more at the state level than at the federal level. I mean, certainly there's some continuing tweaking of things like the Medicare physician and health professional payment schedule to try to pay a little bit more for primary care, but it tends to be at the margin. But I think more meaningful action is happening at states where state governments, through the regulatory mechanisms, are setting goals to increase primary care spending from as a percent of total healthcare expenditures from its anemic 5 cents on the dollar, maybe it's 6 cents in some states, to something much higher. And in my own state of California, our state government has just set a goal for us to get from our current about 6-7% of primary care spending as a percent of total expenditures to, in 10 years, 15 cents on the dollar, which is the highest sort of target for primary care spending as a proportion of all expenditures of any state in the country. So that's really exciting. So this is happening, I think in a variety of states. But as I've thought about this more and looked at how we're starting to implement this in California, I'm having some worries about whether even these really exciting initiatives are going to get us where we need to go, which is fully revitalize primary care for all Americans. So there's some challenges. So when you think of it from the patient's or the public's perspective, these efforts to increase primary care spending are not universal. Often state policies apply to only a subset of the insurance pools in the state. They may do commercial insurance, not include their state Medicaid programs, other insurers. it still leaves patients struggling with the continuous uncertainty of insurance coverage in the United States. We now have people being thrown off their affordable care programs. There's going to be cuts to Medicaid. It doesn't do anything to address the needs of people who are uninsured or people who are in one plan and they change their employer. You get a different employer plan that has a completely different set of clinicians in the network, and they have to switch. So this disrupts continuity of care. Tremendous inequities in payment, where Medicaid in most states pays much less than commercial insurance plans, which leads to then inequity in access to care related to these differences in payment, even if people have coverage. For people working in primary care, this is a problem. You got to get enough payers participating in these primary care investment programs to get to the tipping point. If you increase primary care spending for 15% of your patients, that's just not going to give you the resources you need to really do whole practice transformation. And what I'm starting to see play out again in places like California, what's going to happen is every health plan is going to come up with their own idiosyncratic way of saying, here's how we're going to spend more on primary care. Maybe this plan is going to say we'll spend more if you do behavioral health integration. This plan will spend more if you can do after hours care. This plan is going to say, oh, we're going to create just higher fees, and we'll give you more if you meet certain quality targets, for example. And it's really going to be, I think, chaotic, even in an environment that is encouraging with payers trying to spend more, but it's just going to play out in a very sort of discordant way. And then for state agencies who are doing this regulatory work, it is not a simple matter to look at, like California has hundreds of health plans, different health plan products, to get each plan to report every year. Here's what our primary care spending is. Here's how we're making progress or not making progress towards a target. So it's going to be actually very complicated to administer and enforce when you have such a complicated financing system. So the solution, what I'm proposing, and I've developed this with a number of colleagues, some who are on the call, the meeting here today, both in California and Massachusetts, other places. Of course, Michael Fine tells me after I think, oh, we've come up with this brilliant idea. Well, like 7, 8 years ago, we already thought of this in Rhode Island. So, there's no new ideas, only taking credit for old ideas that are good and need to be rediscovered. So what we're proposing is a common fund for the common good. This is a universal state-administered single-payer program covering primary care services. So you leave intact the general architecture of healthcare financing in the United States, with people getting their insurance, whether they're getting it through an employment-based plan or through Medicaid or Medicare or what have you. But what you do is you essentially carve out payment for primary care services from those insurance pools. And you take a share of the premium dollars or the tax dollars or individual contributions that fund these different insurance programs, and you carve out that funding and you put it into a state-administered single payer for primary care. Call it a public utility. So you have a common fund that's sort of derived from assessing these existing insurance pools. You put it in a common fund that then goes into a public utility to pay for primary care. And you make sure you budget that public utility primary care payer at a level that is your state spending goal. So in California, we're aiming for 15% over several years. So you would say, okay, every health plan, if we're at that state spending goal, has to contribute 15% of the premiums they collect into this common fund to pay for primary care services. And then you make everybody in the state eligible for coverage under this common fund for the common good. You probably have to then raise some additional revenues to cover those people who are uninsured and aren't then subsidized through this assessments put on existing payers. And one way of thinking about this is it essentially functions as a state-sponsored direct primary care program. Now, I think many of you are familiar with direct primary care, but this is where, the individual consumer will pay a monthly subscription fee with a primary care practice. It will cover all the services delivered in that practice. There's now employers who are starting to do this sponsored direct primary care. So this would essentially create a statewide state-sponsored direct primary care program where a patient can move and say, I want care from this practice. That money moves with the patient, mostly paid ideally as a prospective per person per month payment to that primary care practice. You leave fee for service for some things you really want to incentivize. So it really empowers patient to have the money move with them. So advantages. Well, here's just a schematic of it. So let me go over it. As I say, you leave the healthcare financing intact on the front end. Now, this may not thrill sort of, kind of the core single payer folks. I believe it'd be great to just have single payer for everything, but it sort of leaves us intact. The money goes to both public and private health plans in the state, and what you do is assess them. Essentially, you tax them, pull the money into a common fund that pays for this public now utility paying for primary care. The health plans still pay for all the non-primary care services, but the primary care services are now paid out of this common fund. It is the same payment. It doesn't matter which of these health plans you're enrolled in. For primary care, it is the same dollar amount, whether you're in Medicaid for the rest of your coverage, or Anthem Blue Cross, or an Affordable Care Act subsidized plan. It would be the same payment that goes to primary care for universal equitable primary care. So advantages. All right. From a patient point of view, it is universal, equitable, continuous coverage for robustly resourced primary care. Again, always a fear about austerity for public programs, so you have to implement this with a clear statement about what percent of all the money being collected through these health plans has to be earmarked to be transferred into this common fund. So that's an absolute requirement so that it's robustly financed. Administrative simplicity for a patient, you don't have to worry about, again, which health plan am I in? You have universal mobile primary care coverage that moves with you in the state. For a practitioner, oh my goodness, now I have one set of rules. I don't have to worry about dozens of different payers with all different pays, different fee schedules, different rules, different authorization. I have like a very straightforward rule. Ideally, again, every month that this patient is enrolled in my practice, I will get a payment and then I'll get some additional payments for additional services. Needs to be accountability, but much more accountability at the state level for saying, yeah, how we're going to fund this target of, let's say, 15% primary care. You hold practices accountable for meeting, obviously, some quality standards, some accessibility standards to be able to participate in this program. And you really need to, that this would really empower frontline practices by now having payment directly flow to frontline practices. Even if you're in a larger organization, the way I would propose setting this up is the money is really flows directly to those practices. If they're part of a larger medical group or a large, let's say, hospital-run health system, that system has to show that the money has flown directly to the practice and is being used to hire more staff, to provide ambient scribing, to provide sort of care coordination services for people in those practices. All right. Some precedents. So is this even feasible? Could we pull this off? Well, there are precedents for essentially taxing health plans at the state level. Most states tax either some of their Medicaid delegated plans or hospitals or provider organizations to fund their Medicaid programs, partly to pull down additional federal matching funds. So there's clear legal precedent for a state being able to levy essentially taxes or assessments on existing payers, health plans in the state. The federal government actually taxes health plans to fund the Patient-Centered Outcomes Research Institute. So again, another example. There's examples, again, where you have payment for primary care that has been carved out of financing for the rest of the health system, which is how it works now for direct primary care. So you have, people who are getting services under direct primary care have a different health plan, have a health plan that's covering their non-primary care services. And those practices have figured out how to help patients navigate the system. So you're getting payment through the patient for direct primary care and then working with them how their insurance is going to cover referral services, diagnostic services, and so forth. Now, there are, of course, downsides to separate financing for primary care. It is clearly a little bit harder for patients in some way when the financing for the rest of their coverage is not the same as what's paying for their primary care. As a primary care clinician, you have to sort of maybe work a little bit more to help patients navigate this, as opposed to if they're in like one system and all your referrals are going to go to this large health system. You need to make sure, as I say, that the increased primary care spending reaches the frontline practices and doesn't just get stuck in the machinery of some giant health systems that are billing for the services, and that there is some auditing that happens with this. And then there's the politics. I think this is trying to thread the needle in terms of the political feasibility between a complete primary care single payer system, which is obviously really challenging. I, many decades ago, worked on an initiative in California that was trounced. So it's tough to pull off a complete single payer system. But whether this idea of having a primary care single payer system, which is maybe less disruptive, is addressing this critical predicament of imperiled primary care, which health plans, consumers, employers agree needs some really dramatic revitalization, that I think this might be able to get some political traction. So there is actually a bill that's been introduced in Massachusetts to move this forward. I think it hasn't yet got out of committee, but it's in play. In California, I know there's some folks from our California Academy of Family Physicians Primary Care for All Task Force. We, as a state academy of family physicians, have endorsed committing to making this something we want to prioritize for our advocacy work in state policy in California, which is pretty cool to have a major, professional organization for the biggest state in the United States saying, yes, we think it's time to go for this type of single payer primary care program. Vermont, I know, just also had a bill introduced. And then, as I say, Michael Fine from the Pastimes in Rhode Island had a bill that at least got some play in Rhode Island. So I think there is some traction for potentially trying to get some movement on this at the state level. I want to just, before I close, acknowledge some colleagues here. There's a whole, what I'll call the Massachusetts cabal of folks who've been really pushing on this. Wayne Altman, Zuri Song, and Renee Critchlow. Renee Critchlow published a great blog in the blog space called Medium on a common fund for the Commonwealth, which is essentially, for the Commonwealth of Massachusetts. So check that out. You can Google Renee Critchlow Common Fund for the Commonwealth, and it's a really wonderful blog. I would say Renee must have been clairvoyant to publish it in Medium. Anyway, and as I mentioned, let me thank the California Academy of Family Physicians Primary Care for All Task Force members for really helping me think through this collectively and arrive at the determination that we really think this would be the way to make some big change. So as I say, go big or go home. We can tinker, we can fiddle with payment, we can try to even get some of these state policies to increase primary care spend, but I don't think it's going to be enough. I think we have to really take a giant leap to really think boldly about creating if we're going to think of primary care as a common good, we need to have one common fund that is providing the resource for universal primary care, indexed to a much higher level of resourcing the primary care sector. And I think states will be the laboratories for go big or go home transformation of primary care. So love to hear people's thoughts about this. And whether you think this may be something worth moving forward in your own communities.
Thank you, Kevin. As somebody who's been working on exactly this for about the last 20 years, what you just said is music to my ears. But now let's open the floor to everyone's questions. If you have something to ask or share, drop it in the chat. We'd love to hear from you. To get things started, we've got a couple of questions to lead in with. Just for clarity, and I think you really mentioned this, but for clarity, can you talk about the similarities and differences between universal unified funding of primary care and Medicare for all?
Yeah, so Medicare for all is single payer for all healthcare services. So that would be just like Medicare now pays for all sorts of services, from hospital to primary care to specialists to diagnostics to medications. That's what Medicare for all is. I think that's why we build this primary care for all, recognizing it's not comprehensive healthcare services coverage, but I think you could think of it as a step towards potentially Medicare for all. I think if we could succeed in getting primary care for all programs started in some states and they prove to be successful and popular, then it might be logical to ask, well, if this is working so well for primary care, why not just keep going and do this for all services? Um, so that's how it's situated.
That's great. But say we get primary care for all. How do we get the workforce we need to provide all that primary care to the whole population?
Yeah. So I'm going to reverse the question by saying the answer is you're never going to get a an increased workforce, a more robust workforce, unless you start paying more for primary care. So I'm going to switch the chicken and the egg here, because you can't wait for the workforce to materialize, because the reason medical students aren't picking careers in primary care, while even people then train as internists or pediatricians or nurse practitioners or physician assistants, then actually I think the specialty practice just looks more, like a better fit for me, is because it looks like there's more support in those environments. Boy, there's a lot more staff in the hospital than there is in this primary care practice. There's a lot more resources. I'm not managing inbox coverages with patient messages, every day. So that I think until we put the resources into primary care to be able to then hire not just clinicians, but start to hire, more medical assistants, more LPNs, LVNs, more in our practice. Now we have pharmacy technician to help with all the nonsense around getting patients the medications they need. So you start to build out the teams. It says, this now starts to look like a more feasible career for me to work in primary care with more support. Maybe the compensation goes up. Maybe you start to do universal loan repayment for anybody who's working in primary care with these resources. And then you start to get more people entering primary care with these better resource practice. Now, obviously, you have to deal with the transition issue. If you create universal primary care, people are going to expect access to care. So I think you're going to have to get through that initial phases. Now, I think there's ways with better resources you could move people out of, we talked earlier today about in hospitalist practice to getting back to primary care. Uh, uh, PAs or working specialty practices could quickly, so there's a more fungible workforce that I think we could move back into primary care fairly quickly if we resourced it better and made it more of a priority, while we're then priming the pump with getting more people in the training pipeline to start to redirect their interest into primary care.
Yeah, great ideas. Just by the by, our state and local work groups are working all around the country, trying to find ways of funding and increasing the primary care workforce locally, working on new residency programs and new medical schools, because all that's going to be part of the picture, I think. So say we have the workforce we need. How do we get primary care clinicians and practices to locate in the places we need them? And who should be in charge of that?
Right. So underlying this are profound inequities in access to all care of all kinds, and those include primary care. So if there are rural regions, there are lower income urban communities that are way under resourced, whether it's in workforce, whether it's in the availability of facilities. So that's a beautiful thing. With a common fund, you'd have it under much more public planning, and you could say, we are going to now prioritize investments in, for example, California, the Central Valley, where some of the workforce needs are greatest and the access needs are greater, the uh, Inland Empire and San Bernardino, Riverside County. So you'd have much more ability to really under public planning model with a common fund for the common good to prioritize resources to say, okay, maybe we'll actually even give higher payment rates for practices in those communities. And addressing inequities. There's a lot of other inequities related to language access. I think these types of things. I think of historical racism, of now issues around cultures that are inviting for people based on gender identity, sexual orientation, things like that. So I think it would give you much more ability to really focus how you're going to invest in those areas that are most in need to uh, uh, eradicate inequities in primary care.
Great. Lisa Letourneau, do you want to come off mute and ask a question from Maine?
Yes, thank you. Thanks so much, Kevin, for continuing to do this great work. And my question is really about what is it going to take from political will? So clearly, we've got folks in Massachusetts that have been at this for, I think it's what, 3 or 4 years now, 3 or 4 legislative sessions, and get close, somebody bats it down. So the powers that be do not want to let go of what they have, whether it's claims information or revenue coming into the health plan, whatever it is. So it is not, it is a great idea. I 100% believe in it and back it. And I know that the status quo does not give up easily. So what's it going to take? And how bad does it need to get? There's news stories. Everybody's got a story. Can't get into primary care. So who are our allies? What's the political strategy here? It's got to be beyond a good idea.
No, 100%. So um, I think, well, that's just partly what primary care for all Americans is all about, Lisa. So I think it can't just be, doctors advocating. And it comes back to too much self-interest. So um, I think, you can anticipate where some of the resistance will come from, whether it's insurance plans, hospitals, potentially specialists. Um, so I think we have to really solidify our movement building with consumers, with unions, and frankly, employers. I mean, there are some other interests here, such as like employers being a good one that may not be traditionally always on the progressive front of things, but I think are really saying how desperate they are to have primary care for their employees, realize the problem it is to not have a workforce as healthy it could be because of lack of access to primary care. They're starting to do things like sponsor their own direct primary care for their workers because primary care is so hard to find. So I think we need to look where we can start with allies. So I would say in the purchaser community, I would say in starting to build you know, uh, a more movement with citizens movement, with union movement. I think though, then when you think about health plans, this is part of the threading the needle. And now I see somebody in the chat put in, well, we should just go for, Medicare for all. This is a bit of a cop-out potentially and deflating of Medicare for all. But I think it may get less resistance from hospitals because they're saying, well, we're in California, we're committed to increasing primary care spend to 15%. So putting into a common fund doesn't directly threaten the hospitals in the same way it would if you say now we're going to do directly, single payer for all services. I think the health plans, Renee Critchaw's article is great, is saying, when you get right down to it, health insurance should be for higher costs, less predictable expenses. Why are we even thinking of primary care as an insurable expense? Health plans, we're going to do you a favor. We're going to take away from you something that really is not something that typically should be thought of as an insurable loss. It's just a service. So we're going to bring that under state thing. You can now focus on the things that, insurance plans should really be focusing on, which is those less, less predictable, higher cost type services. So I'm not pretending, Lisa, that everybody's going to immediately agree with my arguments, but I think there's a way to tamp down some of the resistance you get from some of the broader, for example, single payer works. And then you need political champions. In our states, we've had Governor Newsom, who's sort of been more willing to consider single payer and put some oomph behind that. So I think you would need some champions in the executive and legislative branches of states. Obviously, I think this will start in blue states where you can really get people to get behind this. So I'm seeing this has potentially, it's not a non-starter when you get to the politics of it.
And
Particularly if states are already saying we're going to spend more on primary care. So you've already got got that sort of momentum going is now fine, we're already committed to this. We're just going to tweak how we're going to sort of organize our funding for primary care to achieve that target.
And can I just sort of hop in that from the Primary Care for All Americans perspective, we really think the political support starts in communities as we help communities figure out how to provide primary care to everyone, and both fix the problem or begin to fix the problem at the local level, get people engaged, and then build that political base for statewide change. Judith Steinberg, I don't know if you're in Massachusetts or Washington at the moment.
I'm in Boston right now. And welcome, Kevin. Thanks so much for joining us tonight. So I spent the reason I'm in Boston, besides visiting my daughter and granddaughter and family, is because I spent the day at the Massachusetts State House for the Mass chapter of the American College of Physicians Advocacy Day. And of course, they were advocating for several bills, three of which are the three primary care bills that are in play at the State House. And I have to say that although I have a good feeling in general from the state reps and senators that we spoke with, that they are in favor of some kind of primary care payment legislation, I don't see that primary care fund or stabilization fund making it through. So it's a big step, a much bigger step than everything else. There's definitely agreement on more investment. And probably, if I had to guess, I would say that probably the bill that's going to pass is the one that's made it out of the Senate to the Senate floor, I'd say.
Yeah.
And that one has, and they all have a primary care prospective payment. And an increase in investment to up to about 15% over a few years. So if we could do that as the first step, it's better to have something
Well,
rather than nothing. If we could do that as the first step where all the payers agree to pay using this model that includes the payment rates, the same risk adjustment, the same quality measures. Couldn't that work?
Judith, and I spoke to somebody with deep experience in understanding government and politics. So, look, first of all, I would say, see, in California, we've already gotten the first step, which is a very, wonderful primary care spending goal, right? So I think Massachusetts is still trying to just get to that stage. So yes, I think that's the stepwise way to do this is you first get your state to back a primary care spending goal. Then you come back and say, okay, now that we have this goal, how are we going to actually effectively get there? And I think as states realize some of the complexity of getting there, this starts to have more appeal. Now, it's really interesting. Our primary care for all task force at California Academy of Family Physicians, and I think we have at least a couple of people from the task force here that may want to actually weigh in. We thought of that option of what you're talking about, an all payer model. So instead of having a common fund for common good, you have let's just call it common payment rules for the common good. So you don't pull off that money like on that graphic to go down to the common fund. You say you leave it at the plans, but you say, okay, just like Maryland has an all-payer rate setting program for hospital payments, we're going to say everybody now has to pay this amount of dollars if it's fee for service, or if we're going to go to capitation for at least part of it, or some hybrid payment, everybody's going to agree to the same payment amount, irrespective of plan. And we try to get Medicaid to do that. And our task force actually concluded that's more difficult to implement and execute than the common fund. Because you get, Medicaid would have to pay way more to get to that average, common payment level. So it put a much more of a burden on Medicaid, as opposed to if Medicaid is pooled in the common fund with everybody, everything equilibrates there on some, essentially cross subsidies from more high premiums for commercial with Medicaid rates. So it gets very hard, and it's really tricky to dictate to health plans, here's how you all have to pay exactly the same way for services. That's so antithetical to how they approach things. So it was interesting. I kind of came in thinking, maybe an all-payer rate regulation way would be the way to go. And I think I was sold from some of the people on the task force that actually that's probably even less viable. So I think that's where we are, Judith, with this.
Okay, thank you.
And 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 I'd say again, that's like think big. I think we need things that are ambitious, right? We need, even if we know, maybe this isn't feasible tomorrow, or it's not going to win a majority. It's how you, like, just in Massachusetts, I think that the bill you're mentioning may not get out of committee that has this fund, but at least it's getting debated and it's
Absolutely.
starting the conversation. So that's how these things go. You get it in there, you get it debated. It may not fare this way, but you have something that's your ambitious, aspirational uh, sort of place you're heading for. And then that actually, I think, helps some other things start to fall into place beyond what would happen otherwise. So I really encourage us to not start with saying this is just never going to be political feasible. Say this would be the right way to do it. Let's put it out there and let's get people talking about this.
Right. Thank
Yeah,
you.
we've often thought that we ought to get a bunch of people running for governor, at least in a couple of small states,
Yeah.
on a platform like this, if for no other reason than to get it out there and get it discussed.
Yeah.
We've got time for about two more questions.
And
Chris,
Michael,
I think you.
can I do a quick one? I saw in there's a lot about
Sure.
how to pay practices. I don't think those are sort of the secondary. I put in a plug for, I think it'd be good to do more of it prospectively. I think that gives practices much more flexibility to hire teams, things like that, instead of paying for a licensed person to bill for each service. But you could come up with your blend of this is fee for service, this is prospective. I think it would have to be one set of rules once you put in a common fund. But I think these are good questions. I think this is where you have lots of latitude to figure out, let's come up once we do this and what is exactly the payment model we want to put in for this public utility with a common fund. Okay.
That's the beauty of using state laboratories. You
Yeah.
can have a couple of different states trying it differently,
Yeah.
and see which process is most workable. Chris, you want to come off mute? You're going to be next to last, and then we'll take one more question after you.
Sure, sure. I too want to say that I am from Rhode Island, like Dr. Fine, and I'm a member of the PNHP group. I'm a recently retired primary care internist, worked most recently at a community health center in Rhode Island. And what I'm most concerned about, and what we're seeing in Rhode Island, some of the initiatives are to begin to deprivatize some of the things that are happening in our healthcare industry. We've had a couple of hospitals that have been acquired by private equity concerns out of state. And these are things that are immediate threats to our healthcare system. And I think working from that, working to break down MSOs, which are draining resources from all practices, not just primary care. So my concern is, are we sort of taking efforts and energy away from an initiative, PNHP, that has been, in place for several years? Granted, there is much work to be done, but we are making incremental progress. And I think, trying to have perhaps too many horses in the game may dilute and perhaps confabulate the issue for our constituents.
All right. Chris, let me try to convince you otherwise. All right.
Sure, sure.
Yeah,
No,
because I think
I'm
we
wide
share,
open.
if you're talking about PNHP Physicians for a National Health Program, right?
Sure.
Yeah, so I'm a member as well and believe in that again. So I think this issue of corporate ownership, of increasingly now investor ownership, of private equity ownership, which is happening now in primary care practices as well as other practices where it started, is a huge problem. So one approach is to try to put in through the regulatory and the antitrust mechanisms to try to disrupt that extractive capitalist financialization of healthcare that is now really to the detriment of primary care as well as everything else in healthcare. But this is how I would see this being very strategic. This common fund for the common good is because you now say these payments are going directly to primary care. So if you are part of a larger corporate structure, right now I see that in larger systems in which I've worked. It's like, oh, even if where money is coming in, there's no accountability to get it to the front coalface of where the practices are. So now you'd say, no, the state is actually going to audit or put in mechanisms to say this payment has to go, and you have to show you're hiring more staff. Uh, you're compensating people better. You are deploying advanced primary care elements like integrated behavioral health care, clinical pharmacists working with medication management. So I think there'd be much more accountability. Second, with these regulations, you could say, when we put in a common fund, you can, if not, I don't know whether it'll be legal to prohibit, you could say there is a limit to how much can go for profit to, let's say, a private equity firm that runs this. So you say, no, of that money that goes in, here, there's a cap on any amount that could be extracted as profit in a way that it's very hard to do that, right? To try to regulate all these players under this pluralistic financing system. So I would love to see how to incorporate into this model ways to really disrupt this corporatization, the financialization that's, I think, really toxic to primary care. And I think that's what I was saying. We're talking about this almost as a direct primary care public model, where it then says, here's a common fund that we're all entitled to as residents of a state. That money goes with me. I have a direct relationship with this primary care team that are my caregivers. And that's now the relationship, rather with it all being like, oh, it's a health plan negotiating with this giant corporate medical group embedded in a giant hospital practice that feels so impersonal. So I think this is much more empowering to both patients, the public, to practices, to have that financial relationship now much more directly under public sponsorship, with the ability then to layer on regulations that really would limit, if not hopefully just eliminate, all the extractive profiteering that's going on. Yeah.
Okay. No, I accept that, and I think maybe there can be parallel paths to achieving the same goals. But the other problem we have in Rhode Island is the disparity in reimbursement between our neighboring states, Connecticut and Massachusetts, and that's something that we struggle with, as a microcosm of the bigger picture.
Well, that's
We
great.
need,
So when we spend 15% on primary care in California, that won't threaten, because people can't just move from Rhode Island, to come to
it's
California.
it's when they spend
Yeah.
15% in Massachusetts, which gives me a wonderful
Yeah.
segue
Yeah.
to introduce Wayne Altman. But before I did, for his question, but before I do, Chris, we need you in Rhode Island to be part of primary care for all Americans. We do this all together. Wayne.
Well, thank you so much, Michael. I know we're wrapping up. I'll try and be brief. And thank you, Kevin, so much for your visionary leadership. This subject is very exciting. And, when we're at our best as physicians taking care of patients, instead of treating them symptomatically, we address the root cause of what's causing their ailment. And in health policy, we need to address root cause as well. And one of the root causes of what ails us in our healthcare system is that insurance doesn't belong with primary care. It doesn't make sense. You could argue that insurance doesn't belong with any of it, and a single payer and physician for national health plan, I could be with you on that. But at the very beginning, at the very least, you have to admit that insurance doesn't belong with primary care. And we have to create a movement to get this political strategies to create the movement. Michael has inspired me about that. And I'm happy to report to you, Michael Fine, that this morning we got word from the Teachers Union of Massachusetts that they're endorsing PC for You. Back to you, Dr. Michael Fine.
All right, thank you, and thank you, Kevin. What you said tonight really did kind of make my heart sing. It's something we've all been working on for many years, but particularly in Rhode Island. It's wonderful to see it get attention in Massachusetts and California, and other places, and certainly, it's a major pathway to providing primary care to everyone. And for everyone, if you ever thought the notion of providing primary care to everyone in the United States in every neighborhood and community would be hard or impossible to arrange, think again. You just heard how it's possible, and possible today. In a few weeks, you'll be hearing at this venue about how they're doing just that in the province of Ontario, Canada, a province of 16 million people, when Jonathan Fitzsimmons joins us from Ottawa. And then a few weeks after that, we're convening people in this movement from across the country and bringing everybody to Cambridge, Massachusetts to learn how communities can take their health care and their health back. But communities aren't some idealized places in the sky. Communities are you and I, our families and our friends, and this process doesn't happen by itself. Healthcare for people not for profit doesn't arrive on a magic carpet. Healthcare for people not profit happens when we all build it and build it together. So please start that local work group. Start tonight or tomorrow and join us in Cambridge. Let's stop waiting for the cavalry to arrive and put our collective pedal to the metal right now. Now I'd like to reintroduce Catherine Gergen Barnett, who'll talk to you about how you can support primary care for all Americans through donations and volunteering. That is after you've started that local work group or started working at the state level, because that's what it's going to take, all of us working together. Catherine.
Wonderful. Thank you, Michael, for convening us. And thank you, Kevin, for your inspiring words. I know that Sophie said and held up the book that you have been a mentor of hers, but I will also put in, even having been on the front lines for decades, you've been a long mentor of mine. And I'm just so grateful that we're all in this together. As we all well know, primary care is a foundation of a strong healthcare system. And the data continues to show us that communities with better access to primary care have better health outcomes, lower costs, and as we also all know, millions of Americans struggle to find it. So we're working together to change that. And Primary Care for All Americans is building a national grassroots movement focused on making high quality, affordable primary care available in every community. But we're small and we're volunteer driven, and real advocacy takes resources. So I am here to just let you know that every amount that you can give really makes a difference. Your support helps drive events like these, produces our newsletters, expands work groups. As Michael put down the gauntlet, starting a work group in every community. And you can also support us by volunteering your time. So if you're able, you can go and visit URL primarycareforallamericans.org. It's not hard to remember, and click donate. And like I said, any contribution really helps and makes us be able to sustain our work over a long time. And additionally, if you're looking to actually help a student or give a scholarship to a member, you can actually earmark your funds, and $200 just covers that cost. Each student or community person that comes can help us build the healthcare system of the future, as Michael said. So bring one person in, and we can do this together. We all need to be in this together to build our future and a healthier future for all of us in our community. So thank you for being part of this movement. Have a beautiful night, and thank you for joining us.
Yeah, thank you everyone for joining us. I just want to say, as a learner, I spend my days learning about how to become a healthcare provider. But in this space, I also get to learn on how to make the healthcare system a better place for myself, for my future patients, and it's so inspiring. We'll be meeting again in 1 month. We encourage everyone to invite someone new, bring a friend, and get involved in our movement. Mark your calendars for April 14th. We'll be hearing from Dr. Jonathan Fitzsimmons, who will speak about primary care for all in Ontario. You can register online at our website, www.primarycareforallamericans.org, or you can also check out our local and state playbook, volunteer, and donate to support our cause. Thank you again to Kevin, to our facilitators, and all of you all. Have a great night.
Thank you, Sophie. Good night, everybody. See you in a month.